Hello, everyone. So today in our SeeLife podcast, we have a very special guest. He's actually one of the pioneers of the corneal surgeries in the United Kingdom, and he's a very, very good friend of mine as well. And as well, I assume he's one of the best and the most expertise in the ocular surface worldwide. So please cheer up with me, Dr. Samer Hamada.
Very much.
How are you doing, Samer? I'm very happy that you accept the invitation today and coming to the SeeLife podcast. And as usual, we have always good time when we go out and good laugh. So, Dr. Samer, we usually were talking before the podcast now about that cataract surgeries are different now than before, and people are more obsessed not only for the vision but for the perfect vision and for the best refraction that outcome from the cataract surgery.
Mhm.
So we're talking that we need to have a hint about the premium IOLs and what is the factor that can improve the outcome from the premium IOLs, especially the factor for the ocular surface.
First of all, thank you very much for having me
Thank you very
today.
much, Sam.
I appreciate the opportunity. Look, I'm glad you brought this topic today because, now we're at age where patients' expectations are really high. They expect perfect visual outcomes after their refractive lens exchange or cataract surgery. So now cataract surgery is really a refractive lens exchange. It's a refractive surgery. And patients' measured outcome is not just about looking at Snellen chart and see what visual acuity is. It's about quality of vision. How is night vision? Are they able to work in different conditions? Contrast sensitivity. So all these new parameters are now important factors to decide if the lens implantation or the surgery is successful. And at age we are, as I said, patient looking for perfection. So if someone come to you for refractive exchange, they expect to have the best quality of vision. It's not about the best vision, it's the best quality of vision. Now, there are things that we're doing and really definitely have a control on in terms of optimizing the outcomes. For example, measuring the cornea, keratometry, tomographies are great now. Looking at the biometry, measuring very accurate biometries, controlling various things. So we have a fair amount of lenses that perform, achieve good outcome for patients. The question is, if you control all that, is that enough to get a visual outcome that the patient expecting and want from you? The last few years, there have been an increasing interest in a couple of things. The first one is tear film and how it affects the outcomes of your surgery. As you know, you're measuring keratometry, you're measuring biometry, relying on very healthy tear film. I don't know if you heard about the dynamic aberrations. So the high order aberrations coming from the ocular surface, particularly from the tear film, varies from minute to minute. That's called the dynamic high order aberrations, meaning that now we're talking in another minute, I measure your ocular surface, your tear film will be different. So you have a different dynamic, different measurements. Meaning that even if you have a little bit of dry eye, you have a variation, a range of dynamic high order aberrations. And if that dynamic remain the same, even after surgery, you still get good visual outcomes. However, if that change, because you self-develop more dry eye, your tear break-up time become reduced, that change now you have a bigger range that affect your vision. Then you get what you call fluctuation in vision, and that's become a source of dissatisfaction with patient. So tear film stability is very important. So second thing is about the role of corneal nerves. I think there is an increased knowledge now and data to tell us about something called neurobiology. So our understanding of ocular surface changed quite a lot from talking about the tear film, the various layers in the tear film, and how to get a good balance and good water and oil and all that, to talking about dry as inflammatory condition. Suddenly we talk about molecules involved in inflammatory process, stability of ocular surface in homeostasis. But now we talk about more neurobiology. So now we believe that the corneal nerves play a very important role in ensuring a perfect homeostasis on ocular surface. Now, why are we talking all that? Because ensuring you have a perfect homeostasis in the ocular surface is a key success in your surgery. You're going to get a very accurate biometry, good K readings, good good measurement of the lens implant. Then you're going to achieve the target because the vision is going to be stable for a long time after surgery.
That's just that's very interesting about the what you mentioned about the dynamic part of the refraction and the ocular surface. So that get us to a question. So if we have a dynamic, so first of all, how to do the best measurement with this dynamic problem? And after you do the measurement, how to preserve the surface of the eye to be the same and not to be dynamic, which in turn will change the refraction after the surgery.
You cannot change the dynamic because you all will have range, right? From time where your eye is tired, you not have a good tear film, could be digital eye strain, could be various environmental factor, to time where what? You have truly a dry eye. So there is a range from good tear film to reduced tear film. And you all used to that range. So you're fine. For you can still can function and see well, unless you got break that range, normal range, and you start to feel your eye struggle. See, my vision blurred. People say, end of the day, I cannot focus, my eyes tired, all that. That is when you breach that dynamic. Anyway, so we're talking about the surgery, right? So we measure the eye in your normal variations a day. As long as your tear film is not too bad, so you have a kind of stable tear film, then you are ready to do the biometry. And that's why someone come and they have a reduced tear break-up time. I'm concerned about the measurement. That's my priority, right? But also I'm concerned about what's going to happen after surgery if the surgery itself made that dynamic or that balance not very good, means that suddenly have the reduced tear break-up time, the tear film start to become more insufficient, and then they start to struggle. Moving them from the range to outside the range after surgery, that way the patient start to become unhappy because then suddenly they manifest fluctuation of vision, feeling uncomfortable, and then they feel that the surgery brought something they never experienced before negatively, unfortunately.
Yeah. So if we want Samer to apply this to reality now and want to have like a scheme, so now we want at the end of the video to know for every surgeon who's starting the premium lens to have a scheme to follow so that he can know how to calculate the lens, to choose the patient, and how to optimize the tear film before doing the surgery. So let's first to talk about, first of all, what is the test you do for the ocular surface before doing the premium lens, including what tests are for the for calculating the lens, and what is the protocol you do for optimizing the tear film before the.
Excellent.
Yeah.
That's a very good question, right? Because that's also bring another question. If you talk about measurement, right? If I ask you what biomarkers or markers on ocular surface you measure to decide or to help you predict the outcomes of the surgery, you might tell me tear break-up time stability, right? But if I tell you we have two patients, one with very reduced tear break-up time, and they still have to reduce tear break time after surgery, and they're still very happy with the results. And on the other hand, you have someone with excellent tear break-up time, and they still have good tear break time after that, so they didn't have a dry eye, but they're not happy with the results. So would you say that the tear break-up time is a good marker is it a direct correlation between how the stability of tear film or parameter of tear film and the satisfaction of surgery? There's no direct correlation. There is more to that. So relying on one marker is not enough. Relying on multiple markers is good. From tear meniscus height, is there any damage staining on ocular surface, damage to the corneal and conjunctival epithelium? Relying on the volume of the tears, all that important. But there's other things important we don't really always focus on, and it's the patient himself, what their motivation, the expectations. Someone coming with that positive motivation, they're really looking for the surgery, they want to get the best outcomes. Even a bit of dryness is not going to affect the outcome. They're going to still be happy. And they're going to still tell you, I can use a few drops and I'm happy with my results. That is a patient. That is a personality thing, right? Now, so of course you have to optimize the tear film. Otherwise, you cannot have accurate biometry. So you need to measure tear break-up time. make sure it's stable. Once you're happy with stability of film, then you do biometry. So biometry is important. Coming to the measurement itself, the management preoperatively, how to manage those patients. Here I want to step back a little bit and tell you what things happening to make the ocular surface not the right environment, what affect the homeostasis, right? There's a lot of studies now talking about the role of microbiome, ocular surface, and corneal nerves.
Okay.
So the microbiome is actually the usual commensal bacteria, viruses, mites live on ocular surface, both on the eyelid and the cornea and the conjunctiva, and they're separate as well. They found that this microbiome talking all the time to the corneal nerves. Vice versa, the corneal nerves, now especially TRPV1 receptor, what they do, they try to regulate the microbiome on top of the surface of the eye.
Yeah.
And have a mechanism in ensuring that homeostasis, that balance, is a barrier effect to protect the corneal epithelium. And that eventually help reduce the inflammation, stability of tear film. So one, you need to understand, I don't want dysbiosis, which means the imbalance. Dysbiosis is not infection. Dysbiosis is mean that the balance of the normal microbiome is disrupted now.
Yeah.
So we need to restore that.
Yeah.
That's the microbiome. Mm-hmm. So if you need to restore that, you need to ensure the corneal nerves are happy.
Yeah.
Right? You need to ensure that all the accessory system, lacrimal system, the production of the tear products, all working well. Then you're going to have a stable ocular surface before the surgery.
So that's a very good thing and interesting, because usually the microbiome, we usually hear it for the gut more than the eyes, but when they talk about it, they talk about things that can improve the microbiome, like fermented food, like yeast. So how do you think we can improve the microbiome of the eye? Like,
well, first of all, microbiome of the eye is not in isolation of the rest of the body. Good. That's one thing. But also, as I mentioned earlier, they talk to other part of the system, right? To the ocular surface, to the corneal nerves. If you have inflammation coming from dysbiosis of the gut, so the microbiome of the gut are not right, that signal inflammatory cytokines float around the ocular surface, cause more inflammation, affect your microbiome. So it's indirect. That's called the gut-eye axis. And with that, you fully understand now, okay, you know what? That explained to me why some patients have ongoing ocular surface inflammation, but the problem actually they're in their gut, not necessarily in their eye.
Oh, really?
It is. So now back to your question about how to prepare those patients before the surgery.
Yes.
Right. I want to restore the microbiome. The best way to do it is to ask them to do a bit of lid hygiene. Those eyelid wipes to clean their eyes once, twice a day for the week 2 before the surgery. Or even longer, even better. This is number 1. 2, and that's every patient, by the way, coming. We do all the measurement, the parameters. If there's no signs to tell me the patient have a dry eye, I still tell them, I want you to have eyelid wipes. I give them some artificial tear drops to ensure that good homeostasis on ocular surface. And also those drops with added value, I call it, like osmoprotection, help repair the epithelium and all that. Supplement, we all advise them to take omega-3 and vitamin D. So those patients will have all these 4 or 5 items regardless what the ocular surface looks like. That's a standard.
Yeah.
Now, if there are any signs to suggest this patient have Meibomian gland dysfunction, especially those with rosacea, they're going to go in different route. They're going to need ocular surface management. So we treat them as dry eye patients. And those patients will go through the routes where we start with conventional therapies for 6 weeks. If they get better, come back, beautiful. We do biometry, then we're ready for surgery. If they don't get better, there's a time where you think about, I need to work on the inflammatory process. So then we took out cyclosporins. Then we give them cyclosporin for 3 months. Then we see them after that to see the response, etc. They won't go for surgery unless I'm satisfied they have a good ocular surface, no inflammation. They're ready for optimal results.
Okay, that's amazing, and thank you very much for those new stuff about the microbiome. But you don't think the normal gut flora, like if we nourish it by yeast or something, that doesn't reflect on the eye, isn't it?
Well, always reflect on the eye, always help, but that's usually a traditional way we manage things. we don't really look at the gut health. We look at the eye. And a lot of times, if you manage to optimize the surface, that's fine, is okay. But if not, then we start to investigate more. And when in our questionnaire, when patients come before they even enter the clinic, they fill a few pages of questionnaire. And in those questionnaire, we ask everything to know their personality, their habits, hobbies, problems, systemic condition. And we ask specific about any gut problems, any mental health issue, any depression, anxiety, all that, chronic pain, fibromyalgia. They're common things that actually red flags tell you that this patient might end up with chronic eye surface inflammation, chronic eye pain after the surgery.
Yeah. So there is few questions now, just when you are talking, just came to my mind now. First, we need from you just a kind of like a capsule to tell us to tell us what exactly the test for dry eye you do for the before this patient. You say they are a candidate for regarding only the ocular surface, like what is the test, like do you do Shermer, whatever, plus the tear film pickup time, so that somebody like me want to learn this, like have a scheme, solid scheme. And the other question, it will be about the personality. So when we used to do long ago, like the refractive surgery, like regarding cornea refractive based, we usually like to not to exclude people who are more having some issues, to be honest, like psychological issues or something, because they probably will not be happy, and it can lead, sometimes we know some cases lead to attempt of suicide. The third thing is how you talk to patient about the dysphotopsia that might happen or commonly happen, and how you ask him about how you convince him, actually, because it will happen, dysphotopsia in a lot of patients, how you convince him with them that I will do you something like a presbyope correction or extended depth of focus or whatever, but on the opposite side you will see always a shadow or shimmers coming from your side of the eye.
Okay.
So let's start first with the
That's a big question.
Yes,
please. Right.
Yeah.
Very good question.
Yeah.
So first one was about diagnostics we do, right?
Yes.
So if patient come with symptoms, you need one sign, and they are by definition dry eye patients, right? So if they have ocular surface staining, if they have reduced tear break-up time, or osmolarity, high osmolarity. That according to Deuce-Defoe's report, these are how to diagnose dry eye. So by default, this patient have a dry eye.
Yeah.
Okay. So someone have a symptoms. We know symptoms. We do OSDI questionnaire to every patient coming for surgery. 2, we start doing tear break-up time. We measure the blink. We measure non-invasive tear break-up time. We measure tear meniscus height. I don't use Shermer because the tear volume is enough to measure tear meniscus height. And now you're very good. You can use it on a slit lamp, on your OCT, or on the other diagnostics. Like
Sorry, what substitute Shermer now? Like just the tear meniscus is fine.
Look at tear meniscus, bottom and top. This is your tear volume.
Okay.
So you don't need to bother the patient with Shermer. It's outdated, in my view. We have a much better tools now to measure the tear volume.
Okay.
And we give you a lot of wrong information sometimes, as we know, because there's a lot of reflex watering that can
happen,
and that's really mislead you with the result of it.
Okay?
So once we're happy, we've done all the diagnostics, then sometimes especially if say a case, for example, patient have symptoms, but you don't see any signs. You need to be careful, because those could be cases where suddenly become more problematic in future, especially after surgery. So we use tear biomarkers. So we can measure NMP9, and that help us we have other tear biomarkers, but here I'm focusing on the inflammation. MMP9 tells you that there's inflammation. You can also measure osmolarity as well. We have the tool to measure osmolarity, but I believe MP9 is more reliable and more accurate in measuring. If that, then those patients will need treatment regardless, because it's inflamed ocular surface, and the surgery itself, surgical trauma, will make the inflammation much worse.
That's how you measure it, like the MMP9.
It's a tear with tear sample.
Okay.
Yes.
Okay.
So it's an assay on the special device.
Okay. Okay.
The second thing is about those patients who have no symptoms. They have no problem with the eye, right? and you see signs. Those patients are difficult one because you have to speak to them, try to explain to them you need to treat your eyes, despite they be convinced they have no issues. That can be a bit tricky, right? But we do what's right. You have to make sure that you optimize the ocular surface, speak to them. I show them photos. I take photos and I show them what the eyes looks like. It's a very powerful message. When the patients see what we're talking about, they engage straight away and they comply with the treatment. They try to help you because you're helping them. And that makes my journey much easier. And they build more confidence in you because you know you're doing the best for them. Yeah.
Yeah. So the personality as well. Like, how you know that the patient could be happy and about this photopsia? Do you usually in all patients you talk about them? You might have kind of this photopsia.
So first of all, obviously the question I mentioned, bring all those red flags, right? If the patient have any depression, anxiety, which is not uncommon nowadays, they have a chronic pain, they have any issues that can mean that they are likely to have a problem. You talk to patient again when they come to clinic, and we spend a good time discussing various elements with the patients. That discussion, it gives me impression what this type of personality. I straight away ask them, so why you want this surgery? What's your motivation? And then we ask about your lifestyle, your hobbies, and I can gauge what they do, who they are. That impression about their type of personality. You can pick up some patients who are obsessive compulsive. Those are patients will be taking on small things and they become obsessive. Those you have to be very careful. Why? Because this surgery is not about I can see, is what I feel and what's the quality of vision, right? And you may want to make sure that actually you meet the expectations, right? And that's why important if someone say, well, I enjoy reading a lot, or my golf is my to go sport, for example, right? You have to make sure that actually your surgery meet their needs and what they're looking for. Second thing about this photopsia. Obviously, this is mainly for patients who having multifocal lenses or also premium lenses. You have to factor their personality. This photopsia is it can be a problem if you cannot adapt to it. So I always bring neuroadaptation into discussion with patient when I talk about lenses options. Any lens needs some neuroadaptation. It's more challenging with obviously more complex optics, multifocality, right? So if they have not the right personality, if they have poor ocular surface, then they might have a lot of problems. So the discussion is very important. And our job as a physician, doctors, is to tell the patient, I think you have a more risk of this. I think you might struggle with looking, coping with this photopsia and so on.
Yeah, I agree completely because I remember like it's not related too much. For example, when you give like fluorescein angiography for the patient when we were residents, so like the patient just surprised, say everything is getting yellow and stuff like that. They are afraid. On the other hand, when we started to tell the patient, you'll expect having like a discoloration of your secretions and stuff. It was very funny. He was expecting to see something like, and he's taking it more happily, like, now, here we are, we find the yellow thing. So I think it's better to talk. Yeah, it's better to talk about the expectations and stuff.
Now, if say that patient, because you asked me what if they're not the right person for premium lens, give them this photopsia, right? Obviously, it's not just about personality. It's a journey. You have to preparation journey from the questionnaire, knowing who they are, what the ocular surface like, what the optics like. It's not just about you measure a lot of things from the pupil size, the angle kappa, angle alpha, optical quality, high order aberrations. All these factors important for someone going to have a special multifocal lens, for example, right? If you've convinced that actually they might not be good suitable candidate, then don't offer it. I will not offer multifocal lens for this patient. We have alternatives, right? So, for example, the enhanced monofocal lenses. You can mix and match different lenses.
What is the most you do in your own practice, Samer? Like, is it the multifocal? No financial interest, I know, but like just thinking, or the monofocal? What do you do?
Well, to be honest, mix depends on. To me, is to do with patients' motivation and needs, what they're looking for, right? If someone really want, they kind of type A personality, very concerned. They want. I tell them, okay, That's why I tell the patients, you have simplicity and complexity.
Yeah.
Simplicity, monofocal, enhanced monofocal lenses.
Yeah.
Complexity, multifocal lenses and various types of trifocal, spiral lenses, all that.
Yes.
And I give them the differences, the options, but I want to make sure that both options are suitable.
Yeah.
So as I said, if someone like this photopsia, they're not right, etc.
Yes.
I make it clear to them. They might be not suitable surgery anyway. They might be not the right person for that. Unless they have a cataract and that they need to do something about it. But someone coming for a refractive exchange, if I don't think there's a right lens to meet their needs and expectation, I would not do anything. Now, the enhanced monofocal lenses has advanced a lot now. And we are able, with a bit of mini monovision, to give patient a good range of vision without too much compromised distance vision. Obviously, this is need another discussion.
Yeah.
We can talk about various types of presbyopia management, whether you talk about cornea procedure.
That's what I was about to ask you now, like really about it, but like it need a whole episode because some people take it personal when they say it should be corneal. They don't but like anyway, that doesn't go like this, but like anyway, some people just take it so serious about this. On the other hand, some people are with, but like we need to talk it in depth and very pragmatic and neutral about it. Yeah.
Look, bottom line, you have to be able to offer patients what's right for them.
Yes.
And if you, for example, that you believe there is a surgery, I don't do it. I don't mind say, I think you should see Mr. Hosny because he done this type of procedure.
He's unlucky patient, by the way.
Good unhappy patient. But what I'm trying to say, if I don't offer something and I believe good for patient, I should not just offer them what I good at. I should offer them everything advanced. It's up to them to choose. It's not my choice, it's their choice. My job is to explain what options balance. I mean, we're lucky because we have access to various things, lenses, cornea procedure, etc. So we have the variety, all that, right? So I can always tell patient whatever available.
Right. Sometimes some people say they have kind of a protocol to put the for like again we'll talk about presbyopia later in details, but for example if you're doing this multifocal or premium lens in both eyes, so some people just say okay, implant the trifocal in one eye and EDOF in the other eye and that's the best combination. Do you think there's a best combination?
I think there is always a good combination, but there's no best combination. The best is what's best for the patient, for specific needs, and what's their optics like. For example, we use multifocal lenses. Now, one of the options which work very well is to have in the non-dominant eye a multifocal lens, but to maintain a very good distance vision, you can use enhanced monofocal or just a monofocal in the dominant eye. That way, the patient have excellent distance vision and they still maintain the range of vision. When you do multifocal lens in both eyes as well, is this advantage. Remember the summation effect from both eyes working together. So if the patient is suitable for, say, spiral lenses, I'll offer them spiral in both eyes. If they're very concerned about the distance vision, the visual requirements, all that, then I will offer more enhanced monofocal in dominant eye and maybe spiral lens in the other eye. Or no spiral lens at all. But they need reading glass for
Do you mind to ask you who's the candidate who is fitting for spiral lens, for example, like which patient will say if this is spiral is for you, for example?
Yeah. So when we started, and I'm one of the very few people who started doing spiral lenses, we were very careful about choosing the right person. And we were really limited the indication to those with healthy eyes, 100%, excellent tear film, no ocular surface disease, optically good, no increased high order aberration. So we're there. And we have really extremely good results. Gradually, when we have more confident, and it's not myself, we were used as meeting the other day, we will have more confidence with the product. We start to say, look, we can expand the indication now. So we start allowing, like what happened with the trifocal lens in the past, right? So those patients with some increased high order aberration, post-refractive surgery, other either optical issues, still can be candidate. And we're seeing very good results. So I think the indication and the range of patients who can benefit from spiral lenses has expanded now. But it's one of the most forgiving multifocal lens in my view.
So I assume I have seen who probably it was I think Arthur coming or somebody just was having some like a program is just to make the patient have a simulation to see what he will see maybe later. So do you have something like that you do with the patient or something similar that you give him idea about what he would see and what he would like? Because it's still like you can talk about the needs. He might think that the intermediate vision, but he might explain it in a wrong way. He actually need more near vision. How you deal with this? How you explain it so you are satisfied yourself before the patient that 100% this is the right lens for him?
Unfortunately, there is no perfect simulator. There's nothing simulate when the lens is inside the eye. And you are a day and night, and that's the truth. Is a reality. You cannot mimic the reality. But there are some research tools used, and I tried some of them. They kind of give you an idea what's this photopsia might look like, what the compromise you get at night. And I tried actually myself on 3 types of lenses: enhanced monofocal, trifocal, and spiral lens. And I can tell you the difference. Obviously, monofocal give you a nice, and this is like simulator. You look at the motorbike and cars next to it, and people walking in the street. And some trifocal lenses, you can see that the glare and halos affecting you seeing the people, the persons on the street as well, because the glare is too much dazzling. Spiral was much less. And actually, in our brain, obviously, monovision was the least. In our practice, we can ask the patient, do you see glare halos? Now, with the spiral, they tell you, first couple of days, I've seen a little bit, but it's now less bothering me also. This is very good message from the patient. And that's why satisfaction among patients is now increased. Obviously, even chair time, talking about the night vision, dysphotopsia, and all that, it's become easy discussion, because I know it's very rare that the patient will be bothered with the night vision dysphotopsis.
Do you remember the camera?
Of course, yes.
So have you ever nowadays, this kind of lenses, it was X-focus, I can't remember the name, the one with like a disc, it's like the camera, like do you use this for like aquifocus, or do you use this for correcting of kind of presbyopic correction, like get it in one eye and the other eye is
so you can create so you can have a human inlays, like the Allotex inlay, which is create a bit of monovision situation. Those patient is like similar to monovision, so you have to test it with contact lens or do a bit loose lens test, just to make sure that they can adapt to monovision. But they don't lose too many lines or distance in non-dominant eye compared with the pure other treatment. But there's something called presbyopia, which is also inlay in deep in the cornea. At the moment, I think that's the least to reduce the distance vision in the non-dominant eye.
You do it with femto and you
have
implant
to
it?
pocket in the cornea, and 250, 300 micron deep in the cornea, and but centration is very crucial for those lenses. But when it works, the outcomes are great.
So that's interesting. They're having this kind of option. I think like 10, 15 years ago, we don't have this amount of option. And there is more, to be honest. The thing now, I know that we took you now by like after your clinic and a long day, and I know like you are really tired, but I would like to thank you very much, Samer, for this. It's really so much information like today, and we haven't finished yet. So we will have another podcast. So we'll talk in details about the presbyopic correction and using the human or the pig's corneas to change the like refractive thing for the eye. And of course, there's a lot more about what you do, because like you are really good in this kind of things. So thank you very much, and we'll see you next.
Thank you very much for the opportunity.
Thank you.
Thank you
very much.
Thank you very much.